Hi, hello everyone. How are you all doing? I'm Dr. Anshul Diwakar and I'm your faculty of anesthesia at Delhi Academy of Medical Sciences. And today we am here with Dr. Gauri Gangakhedkar, who is a very dear friend of mine, who is a associate professor in Tata Memorial Hospital Mumbai, and she is also a fellowship in neuroanesthesia. And apart from that, she has about 50 more things that I can talk about. But all in all, she is one of the best academician anesthetist who I know personally. We have done a part of post graduation together. She was my senior when I was pursuing my DNB course, and today here we have come together to discuss something that we keep getting from you. That, sir, which super specialty branch to choose? Sir, what is the scope of super specialty in anesthesia? Is it necessary to opt for a super specialty course? Sir, I want to do DM because it is the ultimate course, but which specialty should I choose? I'm not very sure. Sir, will my work profile change after doing DM? Will I be respected more? Will I be paid more? Will I have to work less? So, for answering all these general questions about super specialty, I thought she would be the best person because she is not only a great academic teacher, at the same time, she is surrounded by both PGs as well as DM students, and she works with people who have done DM, and she is a teacher to them as well. So her experience of last 12, 13 years of being a anesthetist, of being in a teaching institute, helps you guys understand a lot about what you want to choose in your life. And her perspective would be very fresh. I don't consider my perspective to be very good, frankly speaking, because I've not done any super specialty course and I practice in a very small town. But she's sitting there in Mumbai and she is surrounded by people who are either pursuing it or have pursued. So I welcome you, Dr. Gauri. How are you doing?
I'm good. So I have to give a disclaimer at first to whoever is listening to this. There are only two true things in all of what Anshul said. I work in an academic institute, yes, and I'm surrounded by students who I chat with. Is the second thing, right? The rest of it was just Anshul being nice. Yes,
No,
we
no, no.
worked together in the past where we're more friends than colleagues even then, and now we're just friends. So, but I'm no by no means accomplished or anything of that sort. I just like to chat quite a bit, and we've had the privilege of having some really bright minds working with us as students in both Tata right now and in KEM in the past where I've worked, who are now pursuing super specialties and further careers elsewhere. So I have had the privilege of speaking with them, yes, and I can sort of put myself in those shoes. So I'm sure I can help. But please remember, whatever I'm saying also, take it with a healthy pinch of salt because the decision will be your own. The achievements are your own and the regrets will also be your own. So when you make your decision, make it with your eyes wide open, all right? Not just what we are talking today. I'm hoping this helps you get closer to what you want to do. But yeah, the ultimate decision will be keeping in mind everything that you want to achieve in your personal and professional life. Please make sure you understand that.
Perfect. So this is why we have asked her to do this for you. The perspective is very, very important. So I'm going to start now, and I'm going
Right.
to first ask Dr. Gauri that what is your exact perception about doing super specialty in anesthesia? What are the
So
criterias? What are the things that you feel and you understand that, okay, this is why we have these courses and this is why and how you should pursue it?
So I have to tell you again upfront that I hadn't really given this a lot of thought till Anshul asked me that, do you want to talk about this? And then I thought about it and I did what anesthetists do best, draw up a flowchart and figure out what is the algorithm that I can use to make sure that I make the right decision. And this is sort of what I've come up with. I put in my lives and a lot of other people's lives into this and it seemed to fit. So let's just go over what we're doing. So the most important thing here is, as you're pursuing your course in anesthesia, you need to figure out what it is about anesthesia, which branch of anesthesia is it that you like a lot. Now, you have to know now that anesthesia is not limited to only anesthesia. There are some 9 or 10 super specialty courses. either as fellowships or as FNB or even as DM that you can pursue. Cardiac, neuro, pediatrics, regional, transplant, onco-anesthesia, even trauma anesthesia. There is pain medicine and ICU. So if I have to make like then there is obstetrics. That's the 10th one. So if I have to make an informed decision, first I need to figure out through my MD or just after also, what is it that I like the most? Then I think you have to put it through the FIRE criteria. I'm sure all of you have heard of the FINER criteria for research. This is my take on it. This is my modification of it. First is the F of the FIRE, which is this feasible for me? I cannot sit here in India and then say that I want to work in translational medicine and then come back and provide anesthesia, because that may not really be feasible for you. The amount of time that is required to do all of this may not really work with the time frame you have in mind. Then you need to look at whether it's interesting or not. Like I said before, that's the most important perspective. You're going to live with this decision for the rest of your life. So obviously, the most important thing is to love what you're doing. Then you have the relevance of it. Is this skill relevant today? Like, there was a point of time, maybe 15 years ago, when putting pulmonary artery catheters was the thing. So I know people who've gone to centers where pulmonary artery catheters were inserted to simply learn how to do that. They did workshops. They did all sorts of things to try and figure that out. But that skill is no longer relevant. And that's not what anesthesia is all about. We're not learning only skills. We're perioperative physicians. We're clinicians. So you have to figure out if what you're planning to study is even relevant to your field of practice. And then the E, which is again vital, which is, are you eligible for it? Now, this I'm talking about for all of my friends who are doing their diplomas in anesthesia. I've also done a diploma, and so has Anshul before. If you want to do a DM, first thing you have to know is you're not really eligible for it until you finish your degree. You can do your DNB, or you can work your way through an MD again. That's fine. But if you have to make sure you're eligible for a course if that is your dream destination. Now that you've decided that you want to do a super specialty, hopefully you have something in mind for yourself. Let me give you an example of myself. I'm going to put myself through the flowchart. So, let's see if this sort of fits. So when I finished, I decided that, I think neuro was really interesting. So I wanted to do something in neuroanesthesia. Then the question I had to ask myself was, do I like this so much that I can do this for the rest of my life? Just this and nothing else. If your answer at that point of time is yes, that, this is what I want to do. I feel so much passion for this that I can do this for the rest of my life and I won't really miss anything, then yes, you should consider pursuing it as a DM. But remember when you're doing this, that currently the state of affairs in the country is so that very few centers have exclusive practice for people who've done their DMs. A lot of them still have to rely on doing some amount of broad specialty anesthesia. Very few exclusive large centers will allow you to practice only your specialty. They may have a thing that, primarily you will do this, but on call days you will do that. Primarily you will be posted here, but you may also get rotated through here. So that's something you do have to consider. Then when you've done that, you say, that's okay, I still want to pursue this. What you also need to figure out is there an availability of jobs around you once you're done with this? You don't want to be stuck with a DM where you've invested 3 years of your life, or a DRNB, 3 years of your life, only to find that wherever you intended to settle, those jobs are not available and you have to go back to providing anesthesia to everybody. If that's something that's acceptable to you, again, where you only learned it as a passion and you're willing to provide anesthesia for everybody, that's okay. You also need to take into account your work-life balance and how the pay is for that particular branch. Imagine spending 3 years into a branch thinking that this is going to dramatically alter my pay scale, to find out you're not really getting paid significantly more than your other colleagues. Then, it may not be worth it for you. So you need to assess that and then take your decision. Now, let's assume your answer was no, like it was mine, that I cannot do this for the rest of my life. I don't think that's what I want to do, but I do want to study something else. Then maybe DM's not for you like it wasn't for me. And then you have to ask yourself again, why am I doing this course? Am I doing this because I want to expand my knowledge in a certain field? Do I think that my training was a little lacking through my MD or DNB? Or, do I want to get edge over everybody else in a particular aspect of training? I think I'd be better off with that. Or it could simply be because you want to get certified in a certain skill or a certain skill set, because you're living in a bigger city and you want to get an edge over all the candidates when you're interviewing for places, or when you're joining a team for a better pay or something like that. If you want to do it because you want your knowledge to be better, or you want an edge as far as understanding is concerned, if you're trying to look for a lacuna in your training, you need to look for a good center. What do I mean by a good center? I'm not endorsing any single center, but what I am telling you is the most important thing. You need a center with good volumes. You need a center that does good work, because that is where you will get more hands on training. The more hands on training you have, the better you are. Even if your hours are longer, even if you have to work harder than anybody else who's doing the fellowship, you know that the reward at the end is going to be you are a more skilled anesthetist. This is where it matters. If you are doing it simply to get a certificate, I am not dissing that at all. That's an absolutely acceptable situation, because you could simply want a job. You could simply want to be paid just a little better than your other candidates. You wanted to be considered above everybody else. In that case, it doesn't really matter what sort of center you're looking at. So, in that case, look at the proximity to your house, how the work life balance is. Is this sort of work culture at the place? Those sort of questions you ask at that point of time. I think this is how I sort of I saw went back to myself and I thought why I chose neuroanesthesia and why I chose to do a fellowship instead of anything else. And this was the answer I came about. I don't know if you guys will have other perspectives, but this is my take on it, at least from here.
No, I think this was wonderful, Gauri, because most of the time the question that we get is one, how can we prepare for NEET SS? And the moment I start by asking them, okay, in which year you are, and so just to understand their perspective, where what all they must be knowing. The second question is, sir, can you also suggest in which branch should I do the DM? So then that is a very big point, and I often felt the need to go out and tell people that apart from surgery and medicine, where DM and MCA changes a lot of your work, it also changes a lot of your value in terms of your ability to generate money and the kind of work-life balance that comes along with DM MCH courses in surgery and medicine. So there the trend is more towards doing it for betterment of life. In anesthesia, still, I feel in today's world in 2025, doing a DM is more of a personal choice in terms of the branch that you like, and less to do with what it is going to do with your career or how fast you are going to grow and how much will things change around you, because ultimately the work of an anesthetist remains more or less the same. You might be only doing the specialty that you are wanting, but sometimes you trying to do that specialty now might not be the same when 10 years later you might again be in the same thing. So I'll just share one incidence is very commonly what I've heard from pediatric anesthetists. Now, pediatric anesthetists, like in your fine criteria, you said interest.
Fire, fire.
Fire, sorry. I'm really sorry. Fire criteria, it is interest. So most of the people, they opt for a fellowship in pediatric anesthesia because their primary residency never exposes them to pediatric. So they say, okay, at least we will learn about pediatrics, so we will not be scared of it and we will do better, which is a very good thought. But what happens to them when they go out in practice is that people tag them as pediatric anesthetist and they don't call them for adult cases. So now here you are sitting only doing pediatric hernias and pediatric emergencies, which takes a lot of toll on you in terms of time. But the remuneration between adult and pediatric in most of the places is almost the same. And then you start regretting, ki, oh, if I would have not done this, I would have at least done LSCS, which is like a half an hour job. You go put spinal, write notes and come back. So this is the kind of thing that one has to understand, that whether the likeness for that subject is so strong that you want to continue doing it for years and years. And I think that makes a big reason for someone in anesthesia to opt for a super specialty. I
I
think
think that's a fair perspective to have. But what I would also like to give you a flip side of this same. Let's look at pediatrics if necessary. All of these super specialty branches, no, largely limit your life to say metro cities or tier one cities. Even now in tier two cities, the demand for exclusive anesthetists practicing that field. When you go to tier two, tier three is where you're going to find that I'm trained. I'm a trained pediatric neuroanesthetist, cardiac anesthetist, but I'm having to do other cases. What it also dictates, so it sort of restricts the number of places you could live in. What it also does is it sort of ensures that you cannot really do private practice, which is a freelancer as it is. I can't run from nursing home giving cardiac anesthesia. People do that, but for cardiac and neuro or stuff like that, they form groups. And the groups are not just of the anesthetist. This is a team that they build of surgeons, of support staff and anesthetists who travel together as a team. So if you're looking at cardiac, then they'll have a perfusionist on board as well. They'll have surgical assistants. Everybody who gels together, works together in a group. And we've all worked in operation theaters long enough to know that more often than not, you have sparks flying between surgeons and anesthetists. To actually like someone and say that I'm going to get up every morning, put on a smile on my face and work with you is not an easy task. For people who can do it, it's brilliant.
Doesn't
It
happen
gives
even
them.
when the surgeon is your wife. I can vouch for that.
I, yeah, when the gastroenterologist is your husband, it
Yeah.
does not happen. I do not do that. But yeah, the fact is that's a problem. Like you have to understand that if you're going to limit your life, this is with a DM that I'm talking about, not with a fellowship. That DM and exclusive practice, etc. You're looking at big cities. You're looking at large corporate hospitals that are going to hire you. What you also have to look at is, for particularly, this is not true about like cardiac and transplant, but for pediatric and neuro, most anesthetists believe that their training is enough for them to be able to handle basic neurotrauma, for them to be able to handle basic pediatric hernias and hydrocele. Even in an institute, you'd find this sort of a mindset that it's okay. Like even if I were to give you my example, when I have a baby who's come for a neurosurgery, I do not call a colleague who's specialized in pediatrics. I just simply do it myself, and I don't think I get scared. And honestly, that was one of the reasons I chose neuroanesthesia, was that when I said I don't want to do this for life, like I don't want to do every day wake up in the morning and do tumors. No, that's not what I'm looking at. But it was giving me access to kids, to babies who were just born with their meningomyelocele, really old patients for their aneurysms and their spines, and everything in between, including interventional radiology and critical care, the exposure to IONM and everything. So that's how I chose my fellowship, that it would allow me to do everything. So I don't think I'm going to call a pediatric anesthetist and say, just because this is a child boss, this is yours. There's going to be that overlap for specialties where even broad specialty residents have rotations.
Yeah.
If
And
you
that
choose
is
something.
Yeah, that is a very valid, very, very valid point. And we'll talk about more when we'll talk specifically about neuro, which I consider as a complete DM branch, because again, that is the reason for it, because it gives you the exposure across in the entire spectrum. But yes, very valid points. I'll just summarize it that certain DMs kind of force you to work in big cities, especially critical care, DM cardiac anesthesia, DM transplant anesthesia. You can't expect that you will settle in a city which is tier 2 or even tier 3. Secondly, the pro and con, the both the things are together when we talk about a super specialty course. One, you might not get any other work apart from your super specialty. Two, you might actually have to do everything else apart from your super specialty. So both can be a problem. So again, the criteria that you have put, interest, how much are you interested in doing that kind of work exclusively? So these are the two very valid points. So this is what we wanted to tell you about the part of choosing a super specialty, the general idea of super specialty in India right now, and what should be one's thought process when they are wanting to choose for a super specialty in anesthesia. Is there anything else that you want to add to this?
No, I think what you also need to look at is, you're really young right now when you choose making this choice. When you're making your choice, you have to look at yourself 10, 15 years later and see yourself doing the same thing over and over again. That's what I mean by will you be able to do this for life? Because things have to be sustainable. The adrenaline rush is brilliant. Okay, there is no high like the adrenaline rush that comes from, resuscitating a massive trauma, doing your first transplant, saving a patient in the ICU, and the list would simply go on. But are you going to be able to do this? Is this going to bring you the same amount of joy, or is this going to suck your soul 20 years later? Is a question that you have to answer for yourself because you know yourself best, right? And then you make your choice.
Yeah, perfect. And I often tell these to undergraduates as well who ask me about anesthesia as a specialty when that is not their first choice. So they tell me that, sir, right now I'm enjoying it because I am in trauma and I'm doing this and I'm doing that. And I tell them this is not reality. This first, second, third year of your residency is not what your life is going to be about. Imagine yourself 10 years from today doing certain things which an
The same
anesthetist does.
trauma, and yeah,
if
yeah.
if if that time also you want to wake up at 2 a.m. and go for an LSCS and feel thrilled about it, then you are wrong. So the life after 10 years is what you are going to live for next 30 years. So that should be your criteria. Very good. So yeah. So now we'll come to the second part of our discussion, and now I think we should go to the individual super specialties. And Gauri, I'll like to take your perspective on first, which is your super specialty, that is neuroanesthesia. So can you
So
tell me, can you just, we'll talk about all the super specialties in terms of what is the what is the basic training like, what are the pros, what are the cons, and anything special that we need to look for or remember while we are choosing that particular super specialty.
So I can answer with entire honesty and maybe a little bit of bias, but the fact is that a neuroanesthesia training, either as a fellowship or maybe as an FNB course, also, if even if you're not interested in doing neuro full time, is a complete fellowship, right? I'm telling you because you're going to have patients across the board, like I said, of all age groups, all kinds of society, whether it is all kinds of patients, whether it is trauma or whether it is oncology, it's going to be aneurysm repairs, it's going to be interventional radiology, it's going to be critical care, and you will do it all. You will learn about intraoperative neuromonitoring, how it works, how it functions, all of it. You'll do awake craniotomies, and the feeling is really good. But what it essentially means is that if you're choosing to do neuro anesthesia, you have to choose to do it at a center which exposes you to all of this, whether you do it as a DM or whether you do it, as a fellowship or like a certificate course or whatever it is, because you want to get exposed to all of this to sort of decide if that is, to be able to actually practice it in the future, because your training is incomplete when all of these aspects are not available. This is not to say that all centers provide everything, but you must know that usually, like for a center that doesn't say have trauma, they will have a MOU or a memorandum of understanding with another institute that does practice trauma, where you could be sent potentially on rotation to observe their practices, to learn from them and see what's best for you. So, neuroanesthesia as a DM is also brilliant, obviously, because it means 3 years of intensive training with this. But like with other DMs, coming back and providing anesthesia to other patients may be a little tough because there's so much to cover in neuroanesthesia. It sort of takes over all other aspects of your life, and then you have to come back and give a spinal for a cesarean section. You're wondering, oh, was this the right, if is this much hypotension is okay? What if I can't give a spinal in the first go? Because those are the sort of things that got to sort of get left behind. The regional aspect of it, the neuraxial blockade aspect of it, those you're going to miss through the period of the 2 or 3 years, unless you're in a center where even as a resident you're rotated through general anesthesia at least on call days.
which
You
which
have to take
might
that into
be
account.
which might be a little frustrating because I
Which
recently
might
spoke
be.
to a DM resident, and he was not happy that despite of he doing a DM in some branch, he was being posted every 15 days in anesthesia. Like, sir, this is not what I have come to do for. So in training you don't want to do that because you have got limited time. I've got two questions for you, Gauri.
Tell
Like you
me.
mentioned, I think a very big disadvantage we can say, or a limitation of being a complete neuroanesthetist is that you are pretty away from non-GA kind of cases, because neuroanesthesia more or less is a GA based, general anesthesia based branch. So, do you think it poses somebody, or it kind of dissociates somebody from doing regional anesthesia later on, which is bread and butter for most of the anesthetists, which is LSCS or blocks and orthopedics and stuff like that. So do you think it?
I'm sure it poses a mind block at least at the end of DM. So
Hmm,
that's why, if you're only looking to get an edge, this fellowship is great.
okay.
But if you're looking to do a DM and then having to practice, I'm sure, for the first 4 6 months, it's going to be a little rough. So like we always tell our residents after the residency, if in our center, particularly experience in regional anesthesia is lacking, so we tell them, you go to a place that has OBS, you go to a place that has regional, do this for 6 months, and then you'll feel better about yourself, because it's not that you don't understand it. And after having done a DM, you must have done it through your MD. This is just
Yeah.
a brush up, but take 6 months about it, then you can go on and practice. But I can understand what you're saying. Like, it must bring a lot of frustration that, I've trained for something else
Yeah.
and I'm doing something else altogether. And
Because
I'm sure it's
the thing is
frustrating.
that the thought process after doing DM would be, I want to now put into
Do
this
only
what I've
this.
learned
Yeah.
into practice. So it's kind of a vicious cycle. You want to be in a place where you want to do neuro. So you again don't get practice for regional. And then a point comes in your life where you're like, I can't do this.
So yeah, I mean, but you have to this is for all the students out there. The picture's changing. I'm sure it'll change over the next 5 10 years, where the demand for super specialties will grow, where you will grow with the surgeons of your super specialty. Obviously, there is a difference. You provide a different caliber of anesthesia when you are a trained DM resident as compared to what broad specialty anesthetists could ever provide. So when your surgeons start becoming super specialist surgeons, they will need trained anesthetists, because they will understand the inherent needs of surgery and the patient better. So the
which
picture is
we are
bound
kind
to
of
change.
which we are kind of experiencing as far as anesthesia is concerned. Our
Right.
forefathers were only stuck to OT. Now we are
Hmm.
everywhere. We are in NORA, we are
Where
in
everywhere.
ICU,
Yeah.
we are in casualty, we are in labor analgesia. That is only because the surgeons are now more aware that our role is important. So I think that will extend to all the DM courses as well.
Absolutely. Yeah.
Second, I want to ask you something that is different between a fellowship and a DM in neuroanesthesia. They say that a neuroanesthesia DM has more exposure to neurocritical care part, which kind of gets lagged behind in a just a fellowship course. So, do you think it makes a difference?
Absolutely. I mean, if you're going to practice neuroanesthesia for the rest of your life, it's important for you to figure out the patients that you're anesthetizing, how do they wake up, how difficult is their recovery, and what sort of work they require going in to make them better. With a fellowship, when you have a limited period of time, obviously what gets eaten away is the critical care aspect. And already in our residencies, through the 3 years, at the most, you'll get like, what, 6 months of critical care. And critical care in itself is a DM. And even after doing DMs, you have DM residents who are wanting to do fellowships because they feel, I've not learned as much as I should have. So yes, that's a problem. Your
So
neurocritical care
that is
does
where
suffer in a
DM has
fellowship.
a edge in terms of
Absolutely,
experience
for
as well
sure.
as later on job
For
opportunities.
learning also, yeah, for
Yeah.
learning also. So for job opportunities, you have to have a center that where the neurocritical care is under the anesthetists or under the surgeons themselves. If you're in a big corporate hospital where the critical care intensivists look after the ICU any which ways, then maybe your exposure to critical care won't matter. But your understanding, you're doing a DM with the understanding that I want to be a better anesthetist at this. Your understanding should be paramount. You've done this, putting your 150% into it, then you have to get the best out of it. You have to understand it the best.
Perfect, perfect. So neuroanesthesia we have discussed in detail, and even I feel because when we were doing so, both of us are from a institute for DNB, which is considered to be the one of the best places for neurosurgery and neuroanesthesia. So we were both influenced by the same person, and at some point I did consider that if at all I will ever do a super specialty, I will do it in neuro. But yes, it was cut short very fast because of the place that I was settling in. There was no point in me doing it. So neuroanesthesia, yes, I also feel it's one of the most complete super specialty courses, which also keeps you in touch with all the other aspects of anesthesia. But let's address the elephant in the room, the super specialty that everybody wants to do, not because they like that specialty, is because they are very scared of it. Cardiac anesthesia. So, what is your perspective about cardiac anesthesia?
Also scared of it. Like, the heart scares the shit out of you, living
Yes.
shit out of you. There is no other way to put it. But I think it's a brilliant specialty. Don't get me wrong, but here also, now, if you're going to do a DM, it's the critical care that counts. What is brilliant about cardiac anesthesia, before they were putting PA catheters and feeling all brilliant about it, now they're doing T's. No other anesthetist has that sort of a command over transesophageal echo like the cardiac anesthetist do. We've seen cardiac anesthetists in action. We've seen cardiac anesthetists who are DM. We've seen cardiac anesthetists who are fellows. And they do bring a wealth of knowledge and experience with them when they come back to the theaters, even for broad specialty anesthesia. So that's one of the fields where I would think that, you would feel miserable if you were not repairing complicated TOFs for a living. But the amount of experience you would have in dealing with broken hearts when you come back to a theater is commendable. You would be brilliant at your echoes, transthoracic echoes. You would be fantastic at doing transesophageal echoes. You would be able to put lines where everybody is, failing miserably. And all the sick patients that scare other anesthetists are going to be a piece of cake where you're like, oh, this is what I've trained for. You're going to be worried about giving aliquots of 501 liter of Ringer's lactate because you're going to be like, no, the heart's going to give way and everybody else is going to tell you, hey, this one's heart can take it. But when it is those hearts that can only take 100 and 150 ml of fluid as a bolus, you're who they're going to look forward to. Whether it's going to change your remuneration if you do a DM and then go back to broad specialty is highly debatable. But as a DM, if you're able to form a team for stay in an institute, your pay is going to be phenomenal. It's going to be way more than the other anesthetists make. And the respect that you will command among your peers as a cardiac anesthetist is also brilliant. You may not change your standing in the hospital per se or whatever, but among your peers, obviously, they know that they have to look at you whenever things go south. You're going to be their call for help and you're going to take care of patients brilliantly, for sure. So I think it's something that even if you're not really doing a DM, you can consider as a fellowship simply to get a better handle on how to handle the broken hearts.
That brings me to two very important questions. You will become an amazing anesthetist who is too good for most of the things which normal people won't be able to do. But the first and the foremost question is, will you get a job? Because we know that amongst all super specialties in surgery, the one super specialty that is practically losing its way with every single year is CVTS. We are getting lesser and lesser and lesser MCH residents, and also the people who are already working as great CVTS surgeons, they have their teams, the teams which have not changed over the last decades. So one, do they really get a lot of job opportunities? And two, uh, again, when you are so skilled in managing high risk cases, does it mean that you will get again tagged as a high risk anesthetist? And again, it will become very, very difficult for you, say 10 years down the line, because all you will get is calls with weak hearts, weak patients, frail patients, old patients, congenital heart diseases patient. Even if it is an MRI or even if it is a, say, a T of a child, then you will be called ki, sir, the patient has this cyanotic heart disease and now only you can do it. So all you do is high risk, which of course takes a toll on you. So what are your thoughts about these 2 points?
So let's start with your second question first. I like it better. So the thing is that yes, you'll become a high risk anesthetist. But I don't think there's any harm in it necessarily. Yes, you might feel, bread and butter, the hernias and the hydroceles and the orthopedics, you may feel like they're below you, but I don't necessarily see that as a problem. Primarily because I don't think after a DM cardiac anesthesia, doing DM cardiac anesthesia, you're running around in circles looking for freelance cases. You're either working in an institute or you're
Yeah.
working in a corporate hospital or you're working as a team with somebody. Now, with regards to being a high risk anesthetist, I think you'd be in a better position to answer this if you have to call a specialist anesthetist for a particular case because every other anesthetist is saying no. You should be able to command more respect and definitely command a better fee. Now, this I would say for all of those people who are pursuing their FNB or fellowship. Now, let's come back to your first question because it's a slightly more complicated one. If I don't have MCH surgeons, what am I doing as a cardiac anesthetist? Cardiac anesthesia is not restricted to CVTC. it is also cath lab anesthesia. Now, the CVTC guys are not doing well because the cardiologists are doing brilliant stuff
Yeah.
with their minimal access.
The towers and
But
the
when they
tavis.
the towers and the tavis. So if the towers and the tavis and the rotablators are going to be brought into action, they need fantastic people who will be able to keep those sick hearts alive while they pull all of the stunts that they want to and still keep the patient alive at the end of it.
And I think they will be appreciated even more because they'll be doing it in a NORA setup.
In a NORA
So
setup, you're going to have the patient awake for a lot of these procedures. They may
yeah.
not really be induced. So you have to draw. You have a fine tightrope walk with regards to how you can sort of anesthetize these patients, and your expertise will come to the fore. So this is just my perspective on it. 10 years later, the situation might be different.
Yeah, that is a
Maybe you may
disclaimer
not
I think
really
you have made
require.
at the beginning only. And I think
So we don't
even,
know if cardiac anesthesia 10 years later is also going to be like this. But if you're looking to expand your understanding, this is a brilliant branch.
yeah, I mean, there's
We're
no
not
harm if you
so
just do it
short.
so that
Yeah.
you know how to handle
You
cardiac.
know, understand better.
Yeah,
Sick patients
perfect.
better. Yeah.
So yeah, this is what I actually wanted from you, and this is the perspective that my students want from you. And I, of course, we all know that these are our listeners are pretty adult and they are pursuing their post graduation, so they know that we are talking from our experience now, what we have seen in the last 10 years, and what is the situation today. Of course, nobody can predict the future, but yeah, this is a very I never thought of it. I am more of a pessimist in terms of super speciality, and that is why your perspectives are very, very enlightening. Let's move on to pediatric anesthesia, again a specialty which
Yeah,
people
the
take.
scary ones. Yeah.
Yeah, because they just want to learn, because pediatric anesthesia is something which I really don't think any MD, DNB, diploma anesthesia is ever confident in.
So I think babies are always going to be scary. Even when you're trained with babies, no? If babies don't scare you, you're clearly doing something wrong. The more you understand about the babies, the more they scare you in the anesthesia. With pediatric anesthesia, no, I think Anshul, I think our fear should be more towards pediatric rather than cardiac because at least the CVTC surgeons are not coming because the cardiologists are doing well. With pediatric surgery, nobody really knows what's happening.
Yeah.
We don't have any idea why we're not able to find trainees for pediatric anesthesia, for pediatric surgery. So this is a
So much
branch that
hard
I
work for
feel
them also.
truly I'm sure, but truly, this is a branch that I would sort of have me as an individual would have reservations about. Say advising to somebody that why don't you do a DM in pediatric anesthesia? For now is also fine because we still have some pediatric surgery residents coming up. But by and large, if you look at a gross picture, the number of pediatric surgeons is dropping.
Yeah.
To get an exposure again, there is nothing like it. All the little ones are scary, and when you say pediatric anesthesia, whether it when it is like those ex utero procedures to your 12-year-old, you're looking at four different kinds of physiology, all of which you have to keep in mind, and all different kinds of things that you have to do. You'll be able to provide general anesthesia, you will do regional, and fantastic regional work you will do for the babies because their anatomies are so much more amenable to regional, so much easier, and it is so rewarding to have a baby anesthetized and them for them to wake up happy, pain free, disease free. All of those factors really play on you. But yes, it's scary. They're unpredictable. You don't know what's happening to them. And I would presume that even for the pediatric surgeons, the work is really hard. The risk of litigation is really high. And if you start of looking at maybe the general population trend, also if instead of 12 kids, you're going to have like one kid each, that kid's going to become even more precious to the entire family. So the risk of parents being paranoid of asking you 100 questions, of questioning every prick that you take and every medicine that you give is only going to increase. So it's a
But in
little
general,
scary.
pediatric anesthetists, they do get paid pretty well. That is what
Get
my
paid, yeah.
perception is, because that is one
And they
thing which
still
most of
do
the
a lot
other
of
people are
freelance
not
work.
able to do.
No, and they also do a lot of freelance
Yeah,
work.
they do a lot of freelance work. Absolutely.
So that on from that perspective also that's pretty good. But I know people who've had trouble looking for jobs that required exclusive pediatric anesthesias because no pediatric surgeons. So why would a department hire a pediatric
Yes.
anesthetist when
Again,
everybody else can do the same thing?
this is the limitation, and then they will have to come to a tier one city where they have exclusive pediatric centers. Like in Mumbai,
Correct.
we have so many
Yeah,
pediatric centers, and so there is always a demand for a pediatric anesthetist there.
absolutely. So then
Perfect. So
you have to sort of figure out your demand supply.
yeah, so pro is that you become a pro in pediatric anesthesia. Con is one, the declining number of pediatric surgeons. Two, the kind of work that they do, so little more stressful, more emergency oriented. But I think overall, if you are interested in pediatric per se, you are not somebody who despises children in the OT. Then I think pediatric anesthesia will always give you a lot of satisfaction, because yeah, they do recover magically. Like very very sick babies
Yeah.
also, they come out magically.
No,
So
and they're like I really love the babies. They're happier people,
yeah,
Like the adults will keep complaining.
complaining, yes.
Children are either happy or they're unhappy, and when they're happy, there's no satisfaction like that. So I can imagine what drives people who want to do exclusive pediatrics.
Perfect. Now we'll come to something which is something you are only a specialist on, because I have not even met more than one or two transplant anesthetists, and that is the branch I feel is least touched, and that is a branch which personally I feel requires a DM. It's a huge super specialty in anesthesia. So, what is your opinion on transplant anesthesia?
Requires DM, I think.
Hmm.
Like I would not be comfortable if I found out I was undergoing a transplant and my anesthetist was not a DM. You have to put in like your 3 years of work, and maybe 2 years later, then I may allow you to put in a line for transplant. That's the kind of feeling I have. But for transplant anesthesia, again, fantastic branch. And anybody who's ever done a liver transplant as a trainee, as whatever periods of time, that's a brilliant feeling. I'm not talking about the kidneys, I'm talking about the livers. You have to do one liver and you're like, my God, this is what I'm capable of. When you're shifting the patient into the ICU, that you get that feeling. But and you get paid brilliantly. Now this is that one branch, the more senior you become, the better you're paid. Because like me, when I'm saying कि तुम पहले DM करो 2 साल काम करो उसके बाद मेरा IV लो, that will be the case with the surgeons, with the patients. They want somebody senior, and then there is no room for error. So the more senior you get, the pay is going to be better. But again, tier one cities, metro cities, hospitals only, and not just hospitals. Find a surgeon you like and stick with them, because this is that one specialty where you're going to grow as a group together, right? You're not going to grow individually apart. It's something that your compatibility is going to be tested every single day. Your critical care aspects become extremely relevant. Your inputs are valuable at that point, even as an anesthetist. So, having a DM will sort of rotate you through the ICUs and give you that. But, the question that Anshul was asking with regards to, do you want to do a section at 2 o'clock at night? 20 years later, because you've done 20 years of transplant anesthesia, you're going to be the first person to call to say, can you do this transplant in Raipur, or say hi, some town, some Hyderabad, when you're sitting in Delhi, and you're wondering if this is the lifestyle that you're okay with. This is what you do. And so, I mean, I don't know if that's necessarily okay for everybody. If it is, there's nothing like it.
Yeah. I think the pro of transplant anesthesia is definitely that it is one of the most worthy branches for DM. Con is the stress part that comes, and also the
Mhm.
team part, which at some point of time can become an issue. Not, you can't always think that people will go along with you. You can go along with people. So that team dynamics, if somebody is a very not a people pleaser kind of a person, I feel personality trait will play a lot of role in being a good transplant anesthetist, because it will always be in a big team.
There's
It's not a small team. A transplant team is a big team.
there's also something else. Like I spoke about, when you're doing a DM. Sorry, for transplant anesthesia, when you're doing a DM, it's the volumes of your center that are going to count. I've spoken to a few of our senior residents who've gone for transplant anesthesia trainees or have considered it. There are centers that allow you to do like one transplant in 2 weeks. As a trainee, that is not good enough. When you're eating, breathing, living transplant, is when you're going to become so good that people will want to hire you to be a part of their team. Eventually, maybe you will do one transplant in 2 weeks, but as a trainee, you need to go to a center that is fantastic, that does huge volumes of work, and only then you're going to become better at it.
Yeah. So steep learning curve is also one of the limitations of a transplant
Absolutely.
anesthesia. Perfect. So this was, I think, everything. We have covered all the DM courses that are available. Now we have three non-DM courses that we want to touch.
We've, we've sort of left behind Onco.
Yeah,
And
sorry, sorry.
honestly, when you said first that this is what you have to talk about, I thought we were discussing Onco. But yeah, I'm going to take the initiative to talk about Onco. So Onco is not something I specialize in, but I've worked for the past 5 years in Tata Memorial Center, and I've done a 1 year of SRship, and also something that I think is something that's universal. Not maybe not necessarily something that you want to do DM in, that's your choice. But a fellowship in onco-anesthesia goes a long way because, like with neuro, you're going to see the tiny little babies, you're going to see extremely old individuals, you're going to have access to focus, some amount of it, at least with facial plane blocks. You're going to have access to NORA, you're going to do neuro monitoring. You're going to put in as many lines as you want. You're going to be doing massive transfusions. You're going to be doing the works. Massive, major drawback is the hours. Like there is no getting around the hours with onco anesthesia. You're going to spend long hours in the OT, and that's unfortunately the truth with regards to cancer surgeries. But at the end of your fellowship or DM, you're going to be good at your difficult airways. You're going to be good at your vascular access. You're also going to be good at having difficult patients in NORA. All of us are good at NORA at the end of training, but you're going to have really difficult, really compromised patients. You're going to having to pull stunts that you would normally not think is okay. The patients who you normally say, let's not touch this patient at all, you're going to say, okay, let's do a daycare procedure. Because if I don't do this, the diagnosis does not happen. And that is the sort of courage you're going to require to build. So I think onco-anesthesia is also something that sort of rounds off your training. If you've been in a low volume center where you've not really had access to massive transfusions, lines, etc., you have to be willing to put in the hours.
But tell me, Gauri, onco anesthesia, does it really have any separate place in corporate hospitals?
So I can tell you in tier one and metro cities, all corporate hospitals are wanting to get an onco wing because like we spoke about the other branches, we have a lot of onco surgeons coming up, and they know that onco anesthetists are likely to understand the demands of the onco surgery a little better than other anesthetists. The demand for onco anesthetists will increase. Whether in the next 5 years you want to see DMs working there or not is different. But I know for a fact that if an onco anesthesia centers opening up, they would by and large prefer onco anesthetists to come work with them.
So the future is bright.
Onco Future strength. Onco anesthesia, let's say you do a fellowship and you decide to do freelance work. Also, not a bad idea because colorectal surgeries are still happening in lots of small places, head neck
No, no,
surgeries,
I mean,
plastic
I
surgeries.
can call
So you
myself an
can,
onco anesthetist. I
exactly,
do at least
everybody can
30
do that.
oncos every month. So I know the volume that is there. And most of the onco surgeons are now drifting towards tier 3 cities because the real work
So
is there.
if they did find people who were trained in onco anesthesia, obviously it will make them more comfortable. So, Anshul, when we were in Hindujano, we'd gone for that your caps.
Yes.
There was somebody from AIMS, I think it was Rageshwari madam, who said something brilliant, and I think it stuck with me for the rest of my life. So she said, we are not training and then going back to our homes just like that. We are training so that the surgeons can feel confident that they can do major surgeries with us.
Yeah.
So even with regards to onco anesthesia in particular, or maybe I feel this would be true that you are training so that the onco surgeons who are training and coming to tier two, tier three cities can do more complicated surgeries simply because you are a trained anesthetist who's available.
Who is there?
But
Yes, definitely.
the major drawback, Anshul, hours, the long
Yeah,
hours,
yeah, absolutely, absolutely. The day I
no
do
getting by
one,
them.
yeah, the day I do one onco, that is the day I do only that onco. Then I have no
Yeah.
energy left. By the time you shift on tube and lines and everything, you're like, okay. Now I don't want to do an LSCS on that day. So yes, that's a
Correct.
major thing. And for a freelancer, that also becomes a
That
bit
may
of
bog
a,
you down.
yeah, because then the remuneration can never be equivalent to doing 5 LSCS, which is no risk, no brain, nothing, just go mechanically, give spinal and come back, versus a 10-hour onco case where you're fried. There is bleeding, there is DVT, there is everything, urine output and everything. So, yeah, definitely hours are a very big factor. Okay, so we will quickly now go through the three non-DM courses, one of which uh, I will expect you to talk in detail, which everybody it is gaga about, and almost everybody touches this aspect, that is regional. You are also associated with Ganga, so you have very good idea in terms of the people that you are working with, not in terms of the fellowship that you have done. And then we have something very unique called as trauma and obstetric anesthesia, which even I'm not sure where it is happening and what all things they are doing in.
So, with regards to regional, I think regional is something that everybody has to learn. Right? We're looking at green anesthesia as a future. You have to be comfortable with regionals, even if you're looking to do, say, cardiac anesthesia, neuroanesthesia, or you're doing onco-anesthesia. Being able to supplement your general anesthesia with regionals is a must. So, having a good handle over regional anesthesia is brilliant. There's no getting by it. Do it to finish off, to round off your training. Please, by all means, do something. 6 months, 1 year, 2 years, whatever it is. We don't have DM courses yet. I don't think they're very far in the future. How relevant having a DM regional anesthesia is going to be with regards to your remuneration, I don't really know.
Yeah.
But doing a fellowship is going to be brilliant. You are going to have an edge over everybody else because this is the era of ultrasounds. Even if you say I'm living in a tier three, ultrasound does not matter to me. 5 years later, ultrasounds will be in your hand. You will have a handheld ultrasound device. You don't want to stay 5 years later and say, I can't give regional because I didn't learn ultrasound then. When you're finishing off your residency, if your residency has not given you exposure to regional, please do it by all means. There's really nothing to it. Good volumes and good work is important.
What about trauma and ops?
So trauma, there are I think only 7 or 8 seats
7 seats,
across the
yes.
country,
And that is a
and
FNB program, which is through a
FNB
different entrance
program.
exam as compared to the DM entrance.
Right. And I think they have some 4 seats in Ganga.
Ganga.
So I spoke with someone, I spoke and found out about the curriculum and rotation in Ganga. And I think trauma anesthesia seems like a fantastic approach also. So you're looking at the trauma ICU, you're looking at triage, you're also looking at emergency surgeries to stabilize patients, to do external fixators, you're looking at malunions, you're looking at all sorts of trauma exposure. So this is, where you're going to put your regional blocks. You're going to do massive blood transfusion. You're going to do primary stabilization. So I think it forms a good course for somebody who's worked in low volume centers to get their hands sort of cleared on everything and then move on. But how many trauma anesthetists are required? I'm not very certain because I'm yet to meet somebody who's been employed because they are a trauma anesthetist. And to be extremely fair, the first batch of trauma and FNB trauma anesthesia is yet to pass out.
Okay. So
So
it's
maybe
too young to comment about.
too young to comment, but maybe centers that actually have a lot of trauma coming in. Like I think AIMS has a trauma center,
Yeah.
so I'm sure they will require to hire such people in the future.
Just
But
like
yeah, it
how
seems like a good
AIMS
batch.
are the only people who are hiring emergency medicine people as well.
Yeah, I
Most,
mean, I don't really know. Meaning, a lot of these casualties are now manned by emergency medicine physicians. So that picture's like how that picture has changed over the past decade. Trauma anesthesia may really be
it
the thing of the future.
can be because the training is pretty robust because the curriculum is pretty
Training
much
is
what nobody
fantastic.
really knows in toto. So anybody
Yeah,
who goes on and just touches all those things, I think will become a brilliant anesthetist and an intensive, especially trauma intensive care.
trauma intensive care also. So that would be great. But if you will get hired only as a trauma anesthetist, remains to be seen. You're going to have require big centers that have a lot of road traffic accidents and a lot of trauma coming in.
I
So
think
this may still.
exclusive anesthesia super specialty work uh,
Hmm.
is something which I think is a limitation across all super
Across the board.
specialties,
Yeah, yeah, yeah.
because right now we are still not kind of honed in a way where we consider a particular type of anesthetist as a super specialty anesthetist. So I think we are
Correct.
yet to reach that stage of hiring and people who are hiring, maybe all these people, when they become the HODs of their departments who have done DM, maybe then their perspective will change and they will start hiring specialists for each work.
So now that I have a small perspective to offer about. So we offer DM critical care courses. So according to the NMC regulations, when you start a DM course, you have to show work, and teachers who have worked extensively in that area or have done fellowships. 10 years into starting a DM program, you can only hire DMs for that job.
Okay.
Okay. But that is again in centers that will train for DMs,
For DMs, yeah.
right? So, which is a very small number of centers and which will again be in tier one cities or metro
Yes.
cities,
So
right?
then
So,
they
that,
go kind of hand in hand. Yeah.
the picture will obviously change later, but for now, like, sort of a smaller number of people getting employed like that.
And last is obstetric anesthesia, which I mean, we all are obstetric anesthetists, but yes, they have, I think, few courses which I've
Very, very
seen.
few courses,
Yeah.
fellowship only, very
Fellowships only.
niche.
Yeah.
Very niche. I don't know too many people who call themselves practicing anesthetists who call them. There are, but not too many of them who say I practice exclusive obstetrics. I because I'm a trained obstetric anesthetist, like Anshul said, because it is the bread and butter of anesthesia. Everybody really does obstetric anesthesia. So this may be a certification you can get to round off your training when if you worked in a center which doesn't really have obstetrics, or if labor anesthesia is really your thing, you want to do labor anesthesia alone and you want to spend some time honing that, then maybe this is what it is for you. Because obviously obstetrics, even when you go out into formal practice, obstetrics will form a large chunk of your practice. So you'd be better at it if you're doing this for a year in and out. You will obviously, I'm assuming, have to deal with things like obstetric hysterectomies, as far and few as they may be, and deal with labor anesthesia. Also, that would be great, I think.
And very,
But
very
it's
high
just
risk.
providing a small edge. Very
Yeah.
high risk.
Very, very high risk
Yeah,
obstetric cases or obstetric
correct.
and
But you will be
neonatal.
right. But you will be competing with everybody else,
Yeah.
even after your fellowship. So that's going to be a problem always. Like everybody's going to be like, yeah, so I've been doing this before you were born.
Born, yes.
Is what people are going to tell you, that I have been giving anesthesia for LSCS since before you were born. So I mean,
Before the
it's going to
time,
be a while.
before the time Lebetalol came in market, we have been doing
That
PIHS, and then we know, we
yeah.
have
So
all heard about this.
yeah. So you're going to have there's going to be some time before that mindset changes with regards to obstetrics.
So I think if you will have to sum up the entire spectrum of super specialty courses in anesthesia in two lines, what would that be?
I'm somebody who likes studying. Like, I would love to fall down a rabbit hole and say, I want to understand this better. I want to understand this better. I want to understand this better. I would think that even now, for anesthetists pursuing super specialty, if you are people who want to fall down that rabbit hole, DM is the thing for you, right? You will have opportunities for employment. You may be paid marginally better than your compatriots for a lot of things, maybe much better than your compatriots for a lot of things. But you have to understand the limitations of your employment, where most of these fields you'll be restricted to metro and tier one cities. So going back home, if you're not from a metro or tier one city, may not be a likelihood. Practicing as a freelance anesthetist may be slightly limited.
Little
And
difficult.
you're going to have to work. When you do super specialty, please remember you will have to work as a team with your surgeons. You cannot function independently. The reason why there is a demand for super specialty anesthetist is that you function better together and patient outcomes are better when people are trained together. If you work better together, like, extremely lay speak sort of a thing, partnerships work better even in cricket when the two batsmen understand each other. One person is after something else and the other person is, one person is after winning the match and the other person is after getting their own records. Doesn't really work like that. It's only when everybody wants the team to win that this is going to be effective. So
So
that's
I
going
think
to come in with all super specialties.
if I will have to sum it up, I would say pursuit for knowledge. I
Yeah.
think that should be the reason why you do DM in anesthesia. Otherwise, everybody is everybody and nobody is anybody, sort of a thing.
Yeah.
Yeah,
But I
perfect.
would not necessarily discourage anybody from taking up a DM,
Hmm.
because you are going to have people that are more trained. And I had the privilege of listening to Dr. Adrian Gelb very recently. He would come here. So he said that we sort of turned things around as Indians. So when it's about 7 years ago, the World Federation of Society of Anesthetists did a survey to find out how many anesthetists are there. And we were in the red because we had some 1.5 anesthetists per 1 lakh population. We've jumped that number with the number of seats increasing to 3 students per professor. We've gone into 4.5 anesthetists per 100,000 population, which is a good number. So some numbers say 4.5, others say 6. So if this is the sort of turnaround we see, our demand for better trained or super specialty anesthetists is going to increase in the future. If that is the case, you should obviously study more, get yourself certified. There's no point in studying. And I would think, even more importantly, if you're unsure, which is okay to be at the end of your training, do the non-academic SR posts. Don't do them for 2 months. Give it at least 6 months before you say this is not the thing for me. Because listening to what me and Anshul have to say is very different from actually trying to see what every day looks like.
Absolutely.
So just after your MD is done or your DNB is done, take some time, the first couple of years at least, to say that these are the specialties that interest me. Spend 6 months each in institutes that train you in those and see which fits you best. Moment you find what sings to you, what speaks to your heart, that is what you choose and you go ahead.
Perfect. Perfect. Couldn't have summarized it easier than this. It's a perfect way. Spend some time with each super specialty. And yes, I think the final message that both of us would want to give is that yes, you should go for it. If there are no other personal constraints, it is always better to be what I think we have all read in anatomy is it is better to have read and forgotten than to have never read it at all.
Never read it all. Yeah, for
So
sure.
thank you so much, Dr. Gauri. It was wonderful, and I'm sure my students will love this aspect of super specialties in a comprehensive manner. And if they have any queries, then I'll definitely ask you and get back to them. Thank you.
Sure.
Thank you so much for
Sure.
finding time for us.
Thanks. Thanks, Anshul. Thanks for having me.
Yeah.
Good night.
Bye. Good night.